Thanks for the kind introduction, and it's wonderful to be here, although, of course, it would be so much nicer to see many of you face to face, but there'll be a time for that again. My attempt today is to give you a sort of big, relatively comprehensive overview of some of the things to consider when you prepare for evidence synthesis in public health. And I want to say up front that while I'm presenting, this really draws on what we've been doing as the Munich team, so to speak, with some of those listed on this introductory slide as well, over the last 18 months during the COVID pandemic, but of course also during the years prior on more classical public health interventions. And it also draws on the many different ongoing or past collaborative methods research projects, many of them with this perspective of complex interventions in complex systems. So let me set the scene for today's session, although that's partly been done, and for this talk. Public health interventions, as we heard from Carla, are just a little different from clinical interventions, and I've tried to bring out some of those differences here. We're moving away from the individual level to the population level. We're facing very heterogeneous interventions with very different intervention goals and very different types of measures implemented. And I've listed just a few of those different goals here regarding prevention, health promotion, or health protection. And the measures may target aspects quite close to the individual, so more behavioral measures, or they may be quite far upstream, trying to change psychosocial or physical environments, changing national policy, or concerned with health system management and organization. And unsurprisingly, these sorts of interventions bring about a range of health and non-health outcomes. We have the intended effects of the intervention or intended outcomes by design, and we have many unintended outcomes, and some of those could also be adverse, so we need to be aware of those. And as for other types of complex interventions, public health interventions are highly dependent on context and implementation. Think of these being implemented across different settings, such as kindergarten, schools, or university settings. You may have the same intervention, but operating quite differently depending on these settings. We have variation with context, be it geographical context, financial or political context, social cultural context, and of course the implementation mode will also play a role. So this influences how we do systematic reviews. In my presentation, I'll be drawing on examples from 4 different types of public health interventions, 2 of them drawing on our recent COVID experience, looking at school measures and international travel measures, and then going back in time, looking at a Cochrane review on the effectiveness of environmental interventions to reduce the consumption of sugar-sweetened beverages, and of ambient air pollution interventions, such as low emission zones. And I'd like to ask you, how much experience do you have with public health interventions? So Dario, it would be great if you could share the poll. So how many reviews of public health interventions have you actually been actively involved with? And think of this broadly. So this is not necessarily just Cochrane reviews of effectiveness, but many more. So I think the results give you a nice overview of how much experience there is in the room. We've got about a quarter of attendees having a lot of experience with public health reviews. Overall, more than half of us in this room have conducted public health reviews beforehand. And many of you are interested, and some of you also planning to undertake public health reviews. So thanks very much. The rest of my talk is quite simple in structure. I'm offering 9 tentative recommendations on how to prepare for the synthesis of public health interventions. I'm giving you a rationale for why I think these recommendations are important. I'm offering some tools or approaches of how you might tackle those, and then I'll give you an example from some of our own work as to how this has helped us in doing reviews. So the first recommendation is to place your review in the wider decision-making context. And of course, this relates to us wanting to produce useful and usable evidence for policy and practice decision makers. Having that bigger decision-making context in mind helps us to embed our specific review question in a bigger picture, and ideally to be forward-looking as we address the question. There's different ways of how to do that. Of course, stakeholder consultation is key. And in our experience, it often makes sense to conduct a multi-component, or at least to conceive a multi-component evidence package. You may not necessarily do all of that yourself. And ideally, in the present age, it would be good to set your review up as a living review, but you need to be forward-looking and potentially make it adaptable in terms of its scope, or in terms of the questions, the specific questions changing over time. So here's an example drawing on the ongoing COVID-19 evidence ecosystem project led by Jörg Meerpohl of Cochrane, Germany. And we are leading the public health package as part of this much, much larger evidence ecosystem. And I've given you an overview, a graphical overview of how we've tried to approach this wider decision-making context. So on the left-hand side, we tried to set two overall topics with decision makers. So this was WHO internationally, and in Germany, we set up a public health stakeholder advisory group. So travel measures and school measures emerged as the two themes that we've been working on over the last 18 months. We went through a stage of scoping, producing an evidence map for the travel measures and a scoping review. In fact, the first Cochrane scoping review for school measures. And we then conducted a package of reviews, a rapid living Cochrane review of effectiveness and a complementary scoping review of unintended consequences. Dissemination was something we thought about from the beginning as we conceived this project, and both types of measures, the travel measures and the school measures, are embedded in guidance processes at the international level with WHO and in a German evidence-based guideline on school measures. And you can see that this idea of knowledge translation and thinking about the uptake of the evidence has been embedded throughout. Moving on to my second recommendation, this sort of nicely leads up to, or builds on what I've just been talking about, the importance of formal scoping, for example, through undertaking a scoping review. We feel that this is really important in terms of obtaining an overview of the availability, nature, and sources of evidence. It thus helps inform the scope, as well as during protocol development, the specific eligibility criteria and search strategies of your subsequent review or reviews. And sort of thinking about public health reviews widely, we think it can help address many of the problems that we often encounter later on in the review process. The how-to, I think, is clear. So here's an example. We were approached by WHO asking us to do a review of the effectiveness of travel measures during COVID-19. And we pushed back saying, look, this evidence base is likely to be so complicated. We really want to do some scoping first to make sure that we get our question and our scope and our methods right. And the result of this was an evidence map produced over 10 days. Published in BMJ Open as shown here. And it really helps us refine the review scope, taking a step back from looking at subnational travel measures that were very complex to address, all modeling studies mixing in general social distancing measures with travel measures. So we focused on international travel measures and refined our scope in that manner. And other than that, the evidence map also showed us what to expect. So we knew there was going to be a focus on infectious disease control related outcomes, and that we were needing to look at modeling studies. My third recommendation is make use and make better use than we may have done to date of the potential of stakeholder engagement. This can serve to help prioritize your question and define your review scope, but by and large, the overall objective of this is to make your review as policy relevant as possible. The how, I think, is clear: engagement with potential end users, but you may also want to engage with content experts, and I'll say a little bit more about that later on. It could be one-off engagement at the very beginning of your process, or it could be ongoing engagement throughout. And I've got an example of that. I'm now drawing on the sugar-sweetened beverages review we did, where we set up a review advisory group that was very engaged at the beginning in reviewing the protocol and at the end of the full review process. And one particular issue they helped us with was to treat sugar-sweetened milk as separate from other sugar-sweetened beverages, for example. My fourth recommendation is all about team composition. You want to ensure that your review is scientifically rigorous, so you need the appropriate methodological expertise on board. You want it to be in touch with the work that is ongoing in the research field, so you want content expertise. And of course, you want to make sure that your review is feasible to conduct within a given time frame, so you need sufficient manpower. That has been a particular challenge with the COVID-related reviews we've done. Scoping and protocol development stages are key for ensuring your team composition. And just a mention as well about how to train, how to bring on new systematic reviewers and train novices on the job. That's something you might also want to think about early on. So here's the example from how we dealt with that regarding our Cochrane rapid review of international travel measures. So we knew we needed the methodological expertise regarding modeling. So we brought 4 modelers on board with a wide range of modeling expertise, and they were particularly essential for dealing with critical appraisal of modeling studies, but of course also contributed throughout. And just a comment on training novices for our COVID reviews, we brought on novices that had never been involved with systematic reviewing before. So over the course of multiple reviews, they moved from shadowing the more complicated stages of reviewing through contributing, through actually leading on tasks and full review projects. Moving on to my 5th recommendation, this is about developing a logic model that accommodates a broader systems perspective. So this allows you to think about your intervention in this broader system and to think through context and implementation issues, as well as possible causal pathways leading from your intervention to its multiple outcomes. If you're lucky, there's a good conceptual model in the literature for your area that you can use and adapt for your purposes. Where this doesn't exist, you can create a logic model from scratch using logic model templates to guide you through that process. Or if you're particularly interested in context and implementation, you could, for example, use the CC framework to look at just these aspects. Here's the example from our ambient air pollution Cochrane review, and I don't expect you to read through this logic model in detail or even to be able to read all of it, but to draw your attention just to the fact that we use this to categorize our interventions in terms of technology and infrastructure interventions, educational interventions, and policy and regulatory interventions. We thought about different sources of these, vehicular sources, industrial sources, residential sources. And we use the logic model to inform what context and implementation aspects to do the data extraction for and to do our assessment of heterogeneity for. So here's a question for you. Have you ever used a logic model in your reviews? Okay, so 29% of the audience in the room have used a logic model before, and about 10% multiple times. And then the remaining part of the group is split between those that are not planning to use one and about half that would actually be interested in or planning to use one. So thanks very much. Moving on to my next recommendation, and you can also use a logic model to examine these things. It's about conceptualizing unintended consequences from a broad societal perspective. And as I said earlier on, that's something that makes public health interventions a bit different from clinical interventions, that we've got to often look at society at large, and we want to come up with an appropriate assessment of the balance between the benefits and harms of a given intervention. I'm not aware of sort of hands-on tools that make this easy. So there's something called dark logic models recommended by Chris Bonnell and colleagues. We have used the WHO Integrate framework, which is an evidence decision framework used in guidelines. But really this, I think, requires some more thinking and methodological work. In our experience, it's often hard to look at these broad societal unintended consequences as part of your Cochrane effectiveness review. So it is often merited to conduct a much larger range of searches across many different types of databases and going beyond sort of randomized or even classical non-randomized evidence to sort of search for these things. So here's an example, and I'm stepping slightly outside of the systematic review world. So for school measures during COVID-19, we're in the process of finalizing our scoping review on the unintended consequences. But even prior to that, as part of these German S3 evidence-based guidelines on school measures, we use this WHO Integrate framework to look from a societal perspective at the benefits as well as harms of public health interventions. And just to highlight two potential harms of such measures, we assessed as a guideline panel that there were going to be likely negative impact on health equity, equality, non-discrimination of school measures, such as cohorting or sending half of the children into distance learning. And of course, there were going to be social implications in terms of education or parents needing to look after children and not being able to engage in income generating activities. Right, seventh recommendation is thinking about and categorizing your PICO elements early on with a view to evidence synthesis. And the idea is to make data extraction as informative and efficient as possible, and to prepare very early on for meaningful evidence synthesis. Where you're lucky, you have a good literature-based classification system. We had that, for example, for our sugar-sweetened beverage review. Where you don't have it, you need to come up with a sensible categorization yourself, and there's unlikely to be one right or one wrong way of doing things, but you might want to explore theoretical or causal pathways. Here's an example from the Cochrane rapid review of the effectiveness of school measures during COVID-19. And this is just an excerpt from the logic model that we developed during the scoping review and adapted for the rapid review. And you can see that here we're thinking about the pathways. How do these interventions work? And some of them reduce opportunity for contacts between people. Others make those contacts safer where they occur, so wearing masks or washing your hands. And there's a broad category of surveillance and response measures, as well as a multi-component measure category that cuts across these prior categories. My eighth recommendation, and this is really more a placeholder because I know we'll be hearing lots more about these things. It's about carefully considering eligible study designs and thinking about methods to appraise and synthesize them. And this is, of course, important for all stages of the review process. Dealing with non-randomized study designs and with modeling studies presents particular challenges. I'll skip the how, but move on to our example of travel measures during COVID-19. And we knew from the scoping review that we weren't going to find randomized trials and we were going to have very little high quality observational evidence. So we needed to rely on modeling studies. And without going into the details, but just flagging some of these issues, we struggled to distinguish between more and less informative modeling studies. And as more and more modeling studies emerge now, we need to think of alternative strategies for how to do our update so that we focus more on the informative modeling studies. There was no validated tool for appraising modeling studies out there, so we developed a bespoke tool that worked quite well, but it hasn't been validated. And a particular challenge we found was evidence synthesis of modeling studies. So the richness of many of the simulation studies in particular is the multiplicity of scenarios. So you've got interventions at different doses implemented alongside or simulated alongside multiple co-interventions. Variations in context come into play, so high versus low community levels of transmission, for example. So there is no a priori defined main analysis and subgroup analysis. So we need to deal with that in evidence synthesis somehow. So I think there's a bigger debate to be had about what to do about modeling studies and whether, given their epistemology, whether aggregation of such studies always increases power and whether that's the best way to deal with such studies. My last recommendation in terms of preparing for evidence synthesis is about grading and thinking about grading early on and deciding on a relevant threshold for grading your evidence. So again, this sets you up for meaningful interpretation of review findings, and it can help you apply the domains for grading the certainty of evidence up or down in an appropriate manner. Our suggestion and our experience based on our public health reviews is that the difference from the null is usually a good starting point. And let me show you how we try to apply that to the school measures during COVID-19 review. So again, we were faced with these multiple health and non-health outcomes. So a difference from the null was considered by the team to be the most relevant threshold across these many outcomes. This determined how we assessed direction of effect in evidence synthesis. So we conducted a narrative synthesis and basically looked at positive versus negative effects. It helped us to apply the criteria inconsistency and imprecision. So for example, regarding inconsistency, we didn't downgrade if most of the studies showed a primarily consistent positive or negative effect. But we did downgrade where there were both positive and negative effects across the studies. And regarding imprecision, we were less concerned about the width of a confidence interval, for example. We were more concerned if that confidence interval crossed the null. I'm coming to the end of my tour de force in terms of trying to give you a set of tentative recommendations for how to prepare for evidence synthesis. I've listed them again here as a basis for questions and for discussion. And I just wanted to flag that there's a couple of slides at the end of my presentation with references regarding the tools and approaches, but also the reviews that I've used as examples. Thank you very much for your attention, and I look forward to an exciting discussion.
Thank you very much, Eva. I'm perfectly in time and a very interesting talk. I learned a lot. Colleagues, the floor is open for questions. Please post them in the chat so we can read them out, Joe and I, my co-chair, to Eva. And I see a lot of applauding hands, Eva. I'm not sure whether you see them, but a lot. So please post your questions in the chat. Eva, may I then kick off while other people are now editing their questions? If we talk about public health interventions, there might be two broad categories. The interventions that are applied on groups, communities, and you have, of course, also public health interventions that are applied actually to individuals, to persons, like vaccinations. Your talk, does it apply, you think, to both type of public health interventions or rather to the community-based or the group-based interventions?
Well, I think by and large, public health deals with the population level, although this could be small groups of people, this could be, targeting risk groups, for example, so quite close to individuals that show up in a GP's office and want guidance on how to lose weight, for example, or they could be quite upstream, dealing with very large population groups. I think many of the challenges, the particular challenges of public health interventions come into play when you focus on groups and on these broader systems. But it's also interesting because there may well be systematic reviews where you tackle things from both an individual and a population perspective. And you've just mentioned vaccinations. I think that's an interesting point. Nutrition interventions might be another area where you can look at the benefits from an individual perspective, and then the benefits from a sort of preventative interventions may be quite small, but they may be very large from a population perspective. So these are some of the challenges we encounter with guidelines as well.
Yeah, that's a good point. It's not only that the interventions are either group-based or personally applied, but also the outcomes, of course, can be measured with such interventions, both for vaccination as well. You can have group or community outcomes, but also personal outcomes that can be measured. just checking the chat whether questions have come in.
Yes, we've got some questions, Carl. The first question is, how did the scoping review and evidence map approaches you have used in the COVID work differ from each other?
Actually, they haven't differed all that much. And I think there's an issue of terminology. We used a mapping stage with both the scoping review and the evidence map. And I think that was the key outcome, to get this overview in terms of what outcomes were even being assessed through which sorts of study designs, and where we had critical gaps in the evidence base. But as I said earlier, we were very fortunate and very grateful to Cochrane that Cochrane acknowledged the importance of this formal way of scoping by now actually allowing these Cochrane scoping reviews, at least during the COVID-19 pandemic.
And there's another question which I'm going to read out to you, Eve. I'm not sure whether you can see them. Could you please clarify a bit more the place of system level interventions in health systems? Are they considered as public health interventions?
Well, I think it's sort of coming from Germany. In Germany, there's almost a strict line between public health interventions with this more preventative approach, and those sort of implemented more in healthcare settings. But I think in other national contexts, that is quite different. So it's really a question of perspective. I come to these things from a sort of complexity and systems thinking perspective. And so to me, healthcare interventions and health system interventions are also, share the same features. So I think there's a question of terminology, but in terms of some of the issues I've highlighted, these would also apply to health system interventions. So I'm not that familiar with response to violence and trauma as an area, as a thematic area, but I think the things I said would apply to those as well.
Yeah. And since it's a method symposium, I pick out one more question, Eva. It's also an interesting one. Regarding study designs, how would you approach the inclusion and synthesis of adaptive designs in a public health intervention review?
That's a really good question. I don't have any hands-on experience with those in systematic reviews, so I think I have to pass on that. But I'm sort of wondering whether we might hear something from Hugh or others later on with regards to non-randomized study designs. But adaptive designs, I have no hands-on experience with.
Yeah, it's an interesting one. Adaptive designs are very popular now, increasingly in patient-oriented interventions, indeed. I'm not so sure in public health interventions either. There are a lot of compliments in the chat for you, Eva. So I really encourage you to read that out. There are a few more small questions you might actually apply to them during this session personally. Thank you very much, Eva.